Hello and welcome to an important episode of Implant-Supported Fixed Protheses. We will have a brief explanation about the implants, their history, their types, their procedure of implantation, and the restoration, with a lot of clinical cases that will make this procedure more clear and give us details about some tips and tricks to get the most aesthetic and biomechanic efficient result. The main indication for implant supported restorations when we have a free end distal extension where we have no posterior abutments, and when we have a long odontoless spans. In these both situations, where the classic treatment was a removable partial denture, now having a fixed implant make these removable restorations fixed ones. Also, we have a single odontoless span when it is the most optimum restoration choice is to use an implant. There is three types of implants: the subperiosteal, the transosteal, and the endoosteal. These are the major groups. The first two are used to anchor a denture in a complete denture. We will not discuss them in this chapter. We will discuss these types of implants that are the endoosteal, that are embedded within the bone. The previous structure was the blade that is no longer used now, and this is the most common one, is the root shaped. Let's take a brief history about the blades. They are rectangular in shape, and they are the first endoosteal implants that were used, and they were used as a one-stage system. We will know now the difference between a one-stage and a two-stage. Their success rate was lower than the current root form implants. They needed a large bone site preparation, which made the bone being affected with high temperatures, and the routine immediate loading of these plants decreased their success rate because the fibrous encapsulation around these types of implants was reported. As for the root form implants, they resemble the original root of the tooth, and they can be implanted in both ways, a first stage or by a two-stage. What does that mean? The one stage is that when we do the restoration immediately after we do the implantation. As for the two stage or the bone level, we wait after we do the implantation for about 2 months in the mandible and 3 months in the maxilla for osseointegration to take its place around the implant inside the bone. Then in the second stage, we do the mucosa reflection and open the site of the surgery again to do the final restoration. This protocol was introduced by the Brandmark system. He is a Swedish researcher that suggested the delayed implant loading and the protocol of the restorative procedures that increased the success rate of the root implants from 78% to reach 91% in the mandible. That made this protocol of the brain mark and his colleagues the standard of the implant system. Pregnancy is a contraindication for implantation. Also, an irradiation of the implant site is a contraindication when the patient has an unrealistic expectations with poor motivation. We will now discuss the diagnostic and the surgical guides types that will guide us to the proper citation and inclination of the implants inside the mouth. First, we have this type of scan guide that has a teeth on it that is impregnated with barium. And this type of material is fluorescence. We did a specificity to this interim prostheses inside the mouth to incline the implants with their abutments in the proper orientation that resembles their place inside the mouth with their optimum occlusion. Then based on this design, we did what is called a surgical guide. Then it was printed and resetted inside the mouth. The surgical implantation has been made based on this guide. Then this is the final restoration of the prostheses over the implants. This is another case where we have a missing right lateral and the central incisors. They were replaced by 2 implants when we did a diagnostic waxing of these both teeth. Then we did, after we scanned the cast with the 2 waxing, we incorporated this scan with a CBCT image to orient the precise site of the implant. Then a surgical guide was printed, and this is the final surgical guide. We will see another way of doing these types of aiding of implant citation, where we have a bilateral, in this case, missing posterior teeth. We did what is called a diagnostic cast. This is the first thing. Then we did a waxing where a denture teeth was arranged to simulate the fixed 3-unit prostheses on each side. We did over this waxing, we did a vacuum matrix that was 1.5 millimeter in thickness, and then it was marked, the vacuum matrix was marked with the most appropriate locations and removed from the cast to be implanted on inside the mouth, and the holes were drilled to guide the surgeon for the site of the implant. Say another way for a diagnostic surgical guide. Here we have a lateral missing lateral incisor. We did a placement of a denture tooth that was trimmed from the lingual side here until it was 2 millimeters thick only. Then it was held in place using a light cure composite resin. Over this cast, we vacuumed a matrix and trimmed the height and the contour to get to this height only. And then it was the denture tooth was re-glued to the matrix, and the surgeon can now use it as a guide, both horizontal and vertical positioning. So this is considered a simple way of doing the surgical guide. Now, also another way is to use, when we have a complete denture, we can use the previous denture of the patient before the implantation to use it as a guide. Also, we can use an interim prosthesis as a surgical guide. For example, in this case, we have this denture that was a computer tomography scanned when it was inside the patient mouth, and it was designed using the software to mark the locations of the implants. And this is the final panoramic where we see the optimum parallelism between the implants. Now for general considerations during the implantation is to maintain 3 millimeter between each adjacent implant, and at least 1 millimeter between the implant and the natural teeth adjacent to it. For the anterior part of the maxilla, there should be a minimum of 1 millimeter between the apex of the implant and the nasal vestibule. Also, we should locate the implant slightly off the middle line on either side of the incisive foramen. As for the posterior part of the maxilla, we must leave 1 millimeter at least of bone between the floor of the sinus and the implant, to have a bone that will be anchored apically to the implant. As for the anterior part of the mandible, that is considered the most optimum site for implantation because it has a bone quality that is considered excellent, and it requires the least amount of time for integration. It reported a success in immediate loading in this area due to its good initial stability that the implants has achieved. In the premolar area, we must take care about the inferior dental nerve because this nerve, it goes 3 millimeter anterior to the mental foramen, and it does not get into it directly. Then it turns back posteriorly and superiorly to exit from that foramen. So an implant should be at least 5 millimeter anterior to this foramen. This is an important note. As for the depth of the implant, it is crucial that will affect the crown contour and the pocket depth. It should be placed 2 to 3 millimeter typical to the tooth emergence position. When we place it 4 millimeter, the contour which result in excessive deep gingival sulcus, and if the implant was not placed deep enough, the crown will be short and over contoured. There is a rule for if the interdental papilla will regrow in the space between the teeth and the implant, and this rule is the distance between the bone. This is, for example, the bone and the interproximal contact. If it was 5 millimeter or less, we will get the papilla in place and it will grow to get a natural look. If it is more than 8 millimeter, it is usually not present. Now let's start with the procedure of implant surgery. Patients imagine that the placement of an implant is more traumatic than extracting a tooth, but in fact it is less traumatic. Usually the implant site is prepared with a series of gradual enlarged burrs, where we start with an initial small diameter drill to mark the implant site. A paralleling pin is placed in the preparation for the dentist to check the alignment and the angulation. The placement is influenced by the restorative parameters that we are predicting in the future. This is the guide that we have said and discussed before of a vacuum matrix. Usually the implant is embedded 2.5 to 3 millimeter apical to the desired emergence position of the final restoration. Then the site of the implant is sutured and the healing takes from 2 to 6 months. In the mandible it is 2 months, and in the maxilla it is 3 months usually. We give the patient mild analgesics and chlorhexidine rinses for 2 weeks after the surgery to keep the bacterial population to a minimum during the healing stage. After this time, and when we reach the second stage of surgery, we uncover the area of the implant to attach the abutment, recontour the tissue if it is necessary. During the phase between the reopening or the uncovering and the delivery of the prostheses, the final one, we put what is called a healing cap that will remain until the tissue heals, and it will be replaced by the abutment during the restorative treatment procedures. Now let's see this case of replacing a one tooth with an implant using a closed tray technique with a zirconia abutment and a final zirconia restoration. First, transfer is attached to the implant, then the impression is taken, then we remove the transfer and attach it to the analog, and we replace them to the impression. Then we fix them by using a polyether impression material, and then we do the casting, and the soft tissue can be contoured to mimic the adjacent tooth emergence profile. Then the abutment for the cement retained restoration is selected, which is in this case zirconia. It is seated in the mouth. The abutment is screwed to the implant, and the restoration is cemented to the abutment. Here we have an implant terminology table that we will get to it at the end of the chapter. First, I want with you to see the pictures and understand these concepts via studying some cases. So we will get to this at the end. Now let's see the implant. Does it have types? Yes, it has. We have here the titanium screw, has this shape. The type plasma sprayed screw. This is it. This is the titanium plasma sprayed cylinder, and this is the zirconia. Of course, each one has its own indications, but it is not discussed in this chapter. After we do the surgery, we must close the space of the implant by using what is called a healing screw that is placed in the initial healing phase of implant placement, and the soft tissue is sutured over the implant and over this healing screw. Then it is removed when we reopen or uncover the implant in the second stage. Also, a removable prosthesis can be worn over this area during the healing stage. There is a difference of the healing cap when we use it for a one-stage surgery or a two-stage surgery. If you use it for a one-stage surgery, it is called the interim abutment. This is it. It has this shape. If we are using a second two-stage surgery, we use the healing cap. It is an abutment. It is a component of the implant which is screwed to the implant directly, that it is eventually it represents the crown that we prepare in the normal fixed prosthesis. So the abutments, if they are cement retained, they may be shaped like a conventional crown preparation, but if they are screw retained, they are fixed in their shape. Their length ranges from 1 to 10 millimeters. Let's see what are the types of the abutments. We have the standard one, that its length is selected to make the margin either subgingival or supragingival. As for the fixed cemented crown, it is much like a conventional post and core restoration. If it is screwed into the implant, we have a prepared finish line and it receives a cemented restoration. As for C, which is the angled, it can be screw or cemented, and when we have to correct the implant misalignment, we use an angled abutment to correct for aesthetic or biomechanical reasons. As for the tapered, it can be used to make the transition to the restoration more gradual in larger teeth, and it is considered aesthetic, this type of abutments. It can be also screw retained. It is only screw retained here, they are saying. As for the non-segmented or the UCLA, it is screw also. It is when we have the restoration that is being built directly onto the implant, when we have no intervening abutment. This direct restoration technique is called the UCLA. The abutment and the final restoration can be one piece, but it is subjected to fracture by time, and it can be hybrid, where the abutment is attached by screw and the final restoration is cemented, like this case. There are two screws that attach the abutment to the implant, and the first one is called anti-rotational feature, where the one component of the abutment, which is the hex, must fit the hexagon of the implant. Then another screw that independently tightens the component together. So there is a first engagement of an internal screw between the hex and the implant. Then there is another screw that um, fix the whole components. But when we have multiple unit restorations, the hexes cannot be engaged due to the lack of parallelism of the implants, so we use a non-engaging direct abutments in these cases. Here at the neck, this is the anti-rotational hexagon, and this is the direct attachment. Now let's discuss the implant analog. What is it? It represents exactly the top of the implant fixture in the laboratory cast. They screw directly into the impression coping, which is the transfer, after it has been removed from the mouth, and the joint components are returned to the impression before the definitive impression material is poured. The transfer is attached to the implant. Then we do the impression with an open tray where the site of the implant is opened through the tray. After the fixation of the impression material, we remove the screw to untighten the transfer. The impression now has the transfer within it. Then we attach to it the analog, and we fix it using a polyether impression material. Then it is poured with to a cast to get an duplication of the transfer that duplicates the orientation and angulation of the implant in the patient mouth. And this is a cross-section view of the impression where we see the analog inside the impression, and the where we see the transfer inside the impression, and the analog that is attached to it. This is a case of an angled screw abutment where we have two implants of the laterals. We see that the path of insertion of the left is in place, but there is a problem with the right lateral incisor. So an angled abutment of 28 degree is designed. There are several types of the transfer. This is the one piece transfer we said before, that is screwed into the abutment, and the two-piece transfer for the closed tray. It is attached directly to the fixture. If the abutment does need to be changed on the cast, it should have a flat side if angle correction is necessary. A two-piece coping, this is C, which is for the open tray, is used to orient the anti-rotational feature or to make impressions of very divergent implants. So these align the anti-rotational feature where we have multiple implants that are divergent and they have different anti-rotational direction, so they all must be aligned, and the abutment must be fixed aligned to this direction of the anti-rotational screw. Advent of digital technology, the digital scans of the implant is possible, where we use an impression coping, where we use a scan body that is scanned from the digital scanner. The scan file can be exported to the software for virtual analog to be placed in a virtual master model. The program enables the placement of a virtual abutment and fabrication of a crown through the CAM kit technology. In this case, this is the intraocular scan body. It is scanned through an intraocular scanner, and it is converted to an language image file. Then the virtual design of the occlusion is being made, and we have the buccal view of the definitive crown, and this is the occlusal view. We have two implants and one prepared second premolar. The implants were attached together but the normal teeth was left without the attachment to the implant, and we will see now why. In this case, we have a large mandibular defect created by a shotgun wound. The metal substructure of a metal resin prosthesis evaluated on the 3 implants in the defect. The denture resin can effectively recreate the soft tissue color and contour in the completed restoration. This is the metal resin restoration over the defect. Let's discuss the fixed dentures of an edentulous patient. We have 3 implant options: the complete metal resin fixed dental prosthesis, a metal ceramic fixed dental prosthesis, and a zirconia ceramic fixed dental prosthesis. The framework can be metal or it can be the new material, the PMMA, which is a polymer that is used a framework in combination with the ceramic crowns. This is the CAD/CAM PMMA surgical guide and diagnostic tooth arrangement. We see that it was also used as a guide to evaluate the smile line, and then we did the bone leveling here to correct the smile line, and this is the final fixed implant prosthesis, and this is the final result where the smile line has been corrected. It was before high and now it is sufficient. In this case, there we used a metal ceramic supported restoration or denture. It is indicated if we have an adequate bone and soft tissue contours are available, because it is considered heavy in weight. It is indicated where the patient has recently, within 5 years, lost their natural teeth, which means that we have adequate amount of bone that can tolerate the weight of the denture, the fixed one. As for patients with severe bone loss, there is probably only one option: a removable restoration. We see during implantation of 4 or 6 in an edentulous patient that the implants are tilted. Why do they tilt it? To compensate for the rigid deficiencies and to increase the length of the implant that can be placed. So they angle the implant inside the bone, which represents a feasible treatment option. This is a metal resin. The first, then B. C, we have zirconia ceramic restorations, and this is the frontal view of it. The E, F, G are the substructures of a titanium framework. The one-stage surgery is considered risky, but especially when you have an initial stability, we can do an immediate load surgical and prostheses applications. We can give a definitive screw retained metal resin prosthesis 2 to 4 days post the operation with the use of 4 to 6 implants. Like in this case, where we made a surgical guide to determine the amount of bone reduction, the implant was prepared using the surgical guide, and an acrylic resin framework is placed before the implant placement to verify the implant positions. The abutment F, we are in F. The abutments screwed into the implants, then an acrylic, this is the G, acrylic resin framework with the waxing sleeves to fix them during the impression, fix their position. And this is to record, this wax sleeve can be used to record the occlusion relation. This is the metal framework evaluation. In this case, we used an tilted or angled abutment to improve the aesthetic restoration, and a cement retained restoration would be necessary to avoid the hole through the facial surface. This is the 5-year follow-up of an all-4 fixed prothesis of denture. Discuss some important concepts about the connection of an implant. For implants, they should be joined so that the forces may be more equally distributed over the multiple implants. One implant should be placed for every tooth to be restored. When implants that are longer than 30 millimeter can be placed in a dense bone, 2 implants for every 3 teeth being replaced are acceptable. As for the cantilevering, we can cantilever for 5 fixtures in the anterior part of the mandible. Also, we can cantilever to the first molar, that it is also possible. As for the connection between an implant and a natural tooth, it can create an excessive forces because of the relative immobility of the osseous integrated implant in comparison with the functional mobility of a natural tooth. During the function, the tooth moves within the limit of the periodontal ligament, which will create a stress at the neck of the implant up to 2 times the implied load on the prosthesis, and we will get a potential cement failure and screw loosening and failure of the components of being fractured. We must have multiple implants or natural tooth abutments that should be used, and if we were able to do a keyway between the implant and the natural tooth. To solve this potential problem, we can use the telescopic coping, where we have an restoration that is cemented to the natural tooth, then another layer of a restoration that is re-cemented and attached to the implant prosthesis. The other layer is cemented with an interim cementation. This is the telescopic coping. This are. As for the complications that may be encountered is the bone loss. If we get more than 2.2 millimeters per year, we must be concerned, and there are several factors that affect the bone loss, and the inappropriate size and shape of the implant, inadequate number of implants, or the positioning was poor. When we have a poor quality of or inadequate amount of available bone, when we have an initial instability of the implant, compromised fit of the prosthesis, where we have improper design of the prosthesis, where we have excessive occlusal forces, some systemic influence like tobacco and diabetes. Also, if there is a bone loss that reaches 25 to 30%, we must revision the surgery that a surgical reconsideration is taken. A surgical reconsideration is taken. Another complication includes the fracture of the implant components, and it is due to the fatigue from the biomechanical overload, and there is a special equipment to remove the fractured fragment. But this type of failure, it is subjected to laboratory poor procedures, or there is wrong in the prosthesis design. This is the tool that can be used to remove the broken fragments of the implant. As for this type of fracture, it can be repaired with a welded laser repair. The writer surpasses the two-stage and prefers the two-stage surgical technique, and to be the first considered treatment for any partial odontoless patient. So we have seen the implant body that is embedded within the bone, how it has several shapes, and also it varies by the component of the metal used. We have seen the healing screw, which closes the top of the implant until we reopen the or uncover the implant during the second stage of surgery. We said there is a difference between an interim abutment or a healing cap, that if we are using a one-stage surgery, we use an interim abutment, that it is used to maintain the opening through the tissue until the restoration is completed. It is placed immediately onto the implant in a one-stage protocol, but when we have a two-stage protocol, we use the healing cap, that it is also attached to the abutment to protect the internal threads, and it is used until the restoration is being completed. We have seen the types of the abutments and how they can be angulated or tapered. We have seen the hex driver, which is used to place and remove the screws that fix the abutment to the implant, and it can be short with 19 millimeter for the posterior area, and it can be long for the anterior area, that it is 24 millimeter long. And the abutment, impression coping, or the transfer, it is used when we are taking the impression to transfer the position of the implant to the cast. And the analog, that is attached to the transfer after the impression is being taken, it replicates the implant for us to use it in the cast. So we had a brief um, concepts regarding the types of the implants and how they are being the procedure of implantation, the types and the terminology of all the components, some considerations during the prosthesis procedure, and some cases that made the concepts clear with all the advanced in the technological aspect that we are living now. I hope that you find it informative, and see you soon. Salam.